Good evening, everybody. We will be discussing about one of the most important topic in medical science today. So that is heart failure. We'll be discussing about heart failure as such, and particularly we'll try to reach a national consensus on how to manage heart failure. Not only heart failure with reduced ejection fraction, heart failure with mid-range ejection fraction, and also heart failure with preserved ejection fraction. And in that particular context, we'll be discussing about ARNI. It is deadlier than many of the cancers, be it leukemia, lymphomas, both Hodgkin's and non-Hodgkin's, breast cancer, colon and rectal cancers. They're all common malignancies. And see, the mortality of heart failure stands at 48% in 5 years. And it is much higher than most of the malignancies. So it has got a very high mortality rate over a period of time. This is a progressive condition. Heart failure is a relentlessly progressive condition. It's just simply the patient will go down the hill. And along with that, the quality of life function of the patient that will also go down. And as the disease progresses, the mortality starts to go up. There are also very high risk of hospitalization. And 9 out of the 10 patients with heart failure are symptomatic even with the standard of care therapy. And nearly 1/3 of the patients with heart failure reduced ejection fraction are very high risk of hospitalization, cardiovascular death, including those who appears to be stable. And each heart failure increases hospitalization, increases the risk of mortality further. Like if I go to one hospitalization with heart failure, the survival, mean survival is around 2.6 years, and that becomes 1.3 years if there has got 4 admission due to heart failure hospitalization. And if you look at the global data, the mean age of the heart failure patient is around 73 years. In hospital mortality around 3.8%. And post-discharge mortality 6 years, at 6 months around 8.6%. When you look at India, mean is around 53 years. It's quite young. In hospital mortality starts anything between 8 to 30%. The Trivandrum heart registry says is around 8.4%, but other hospitals come up with the data of around 30% in hospital mortality. I'll put it maybe around 10, 12, 15% is the in hospital mortality. And post-discharge mortality, 6 months around 26%. So if you see, the mortality rate is quite high. We have got a younger population of heart failure getting admitted, and with a higher mortality, even after discharge also, mortality is quite high in comparison to the global data. So basically in India, we have got a younger age group patients with heart failure with a very high mortality, and also not only in hospital mortality, but also after discharge. Looking at the heart failure survival rates across different continents. So if you look at India, is around 23.3% respectively. This is the youngest cohort, the highest mortality. Mortality is around 23.3% within a year of diagnosis. So mortality in India is around 23.3% within a year of diagnosis, and the only continent where the mortality is higher is Africa. The rest of the place you find the mortality is lower than that in India. And mostly you see the number of cause of death is the cardiac death. The cardiac death accounts for majority of the death in such patients. 1% of the adult population, accounting to nearly 10 million patients in India, are currently having heart failure. Post-admission mortality, anything I'll put 8.5 to 30%. Medication adherence is poor, 25% to 50%. And we have got a relatively young population of heart failure. And the incidence of diabetes is quite high, around 54%, and incidence of hypertension is also quite high, around 42%. So there are 2 comorbid conditions which can perpetuate the heart failure further. So they're quite high in patients with heart failure. And when you look at the 5-year mortality, and this is from the Trivandrum heart failure registry, and 3 out of every 5 patients have died during 5 years of follow-up, with a median survival of approximately 3 years, quite short. Lack of guideline-directed medical therapy in patient heart failure reduced ejection fraction. Frequent readmissions were associated with very high 5-year mortality. Only 25% patients are discharged from the index hospitalization on guideline-directed medical therapy. And importantly, prescription of guideline-directed medical therapy at discharge was associated with lower 5-year mortality. In fact, the mortality can be brought down significantly if you prescribe the patient the guideline-directed therapy from the very beginning, and then the patient adhere to the therapy. So interventions should be aimed at increasing guideline-directed medical therapy so that we can improve the heart failure outcomes in our country. And the goal of medical therapy to increase survival of the patient, thereby reducing mortality and premature death, particularly reducing two main modes, sudden cardiac death and death from progressive heart failure. So there is a pump failure. Reduce hospital admissions and make people feel better means improving their quality of life, at least slow down the deterioration. I'll be a bit brief in that one because we have to speak a lot more important things. It just started in 1986 with hydrogen isosorbide nitrate, dinitrate, so BHFT trial that came up in 1986, followed by the ACE inhibitor trial, Conception, solved, and then came the other beta blockers, and so many merit HFCBs too, and then the rails, that is the spironolactone mineral receptor antagonist came. The Digitalist trial was there in 1997, and then the host of trials came. Then came the ARB trials, and then the last one came was the paradigm heart failure, and of course simultaneously after that came the DAPA heart failure. So basically came the SGLT2 inhibitors. So the focus then shifted to ARNI and this SGLT2 inhibitors. So this paradigm heart failure, this study actually changed the way we manage heart failure today. This is basically angiotensin receptor neprilysin inhibitor in patients with heart failure, NAVIs class 2 to 4 with LV ejection fraction of less than 40%. The primary endpoint of the study was CV mortality or fast hospitalization for heart failure. Quite a lot, many patients, 8,442 patients. So these patients were on enrapil for about 2 weeks, 10 milligram twice daily, then given the single blind active run-in period of the ARNI, so that is sacubitril valsartan, 100 milligram twice daily for 1 to 2 weeks. Then the dose was increased to sacubitril valsartan, 200 milligram twice daily. And then double-blind treatment period came where sacubitril valsartan 200 milligram twice daily versus enalapril 10 milligram twice daily, and the median follow-up was at 27 months. And this therapy on top of standard heart failure with reduced ejection fraction therapy, excluding of course ACE and ARB. So that includes beta blockers and spironolactone and others. The eligibility criteria will be very brief. So basically, we have already discussed the patient has to be 4 weeks or more on ACE or ARB and a beta blocker. NT-proBNP level has to be high. And aldosterone antagonist should be considered for all patients and with a stable dose for at least 4 weeks. Exclusion criteria was history of angioedema, any EGFR less than 30, symptomatic hypotension and or systolic blood pressure of less than 100 millimeter mercury, and then serum potassium high, and or with a patient who is currently decompensated heart failure or severe pulmonary disease. And this is a very large trial. Geographically diverse countries were involved in this trial, and also different races were involved in this trial. So when you look at the clinical outcome, cardiovascular death is reduced by 20%, heart failure hospitalization was reduced by 20%, and overall mortality was reduced by 16%, all were statistically significantly different. The magnitude of treatment benefit consistent in patients with or without any implantable cardioverter defibrillator. We know that patients in heart failure also do have some assist device like implantable cardioverter defibrillator. In them also, the benefit was also seen, and with a heart failure death reduction of 21% and sudden death reduction of 20%. So it is beneficial also in those patients with ICT. When you look at the medical therapy we use, we know that a beneficial in patients with heart failure with reduced ejection fraction. When you look at the magnitude of benefit, ARNI relative risk reduction of mortality around 17%, and number needed to treat for reduction in mortality is around 26, means you treat 26 persons to save one person, and then from dying, basically mortality reduction, and then reduction in heart failure hospitalization around 31%. With beta blockers, relative risk reduction mortality is quite high, 30 for very effective drug against heart failure, and NNT is only 9, and of course relative risk reduction of heart failure hospitalization is around less, is 41% less. Aldosterone antagonist, again very effective agent for heart failure with reduced ejection fraction with a mortality reduction of 30% and NNT of 6, and reduction in hospitalization heart failure 35%. Hydrogen isocerebral dinitrate. So this is used basically for black population where they found to be highly effective in reducing mortality, and the NNT was only 7 with a relative risk reduction of heart failure hospitalization of 33%. When you discuss ARNI, the mortality reduction is 20% and the NNT is 32, means you treat 32 patients with ARNI to save one life. And remember, this is over and above the ACE inhibitor. So basically, this is over and above the whatever the benefit you're getting with ACE inhibitor, and the relative risk reduction of heart failure is 21%, and this is again over and above what you get with ACE or R, at least with ACE. Then once you treat the patient with sacubitril valsartan, and you see the NIH class change, and after 30 days of treatment, a significant, this is before you started the sacubitril valsartan, class 1 symptoms only 8.6%, 73% were on class 2, and class 3 and 4 was around 18%. And after only 30 days of treatment, what you can see from 8.6%, so the 32% have become NIH class 1. And also there is a significant reduction also patient in class 2, and class 3, class 4, so almost 50% there is a improvement in symptom from the class. So symptomatically patient improved, class 3, 4 became class 2, class 2 became class 1, like that. So there is a significant change in NOHA class with the treatment after treatment initiation and seen within 30 days. When you look at the subgroup of heart failure patients, whether it is age 75 years or less, whether there is ejection fraction less than 35% or more than 35%, EGFR less than 60 or more than 60, systolic blood pressure less than 120 or more than 120, or NT-proBNP less than 1615 or more than that. So there is no difference. So this is effective across all the subgroup of heart failure with reduced ejection fraction patients. See the p-value for interaction. So basically, the efficacy is in across all subgroups. It is immaterial whether the patient is young or old, whether the EGFR is 60 or less or more, and also the systolic blood pressure, even it is effective with the systolic blood pressure less than 120. And we look at the ASEAN population in the paradigm heart failure trial, and when you look at the overall, you see the benefit. When you look at the ASEAN also, whether it is South Asia, where we belong, all East Asia, Southeast Asia, global data, So for when you see the primary composite outcome, it's the same. The p-value for interaction 0.94. Cardiovascular death is the same. Heart failure hospitalization is the same, and all-cause death is also same. See the p-value for interaction. So basically, the efficacy is also seen in Asian patients. That includes us also. The illusion of stability of heart failure. 20% of the stable heart failure patients with paradigm heart failure had a primary event. 17% died during the course of the trial. Of the stable patients who experienced a primary event, death preceded heart failure hospitalization, 51%. They died before they reached the hospital. And 60% of these deaths were sudden cardiac death. And these are so-called stable patients. So ARNI should be started as early as possible. Do not wait till deterioration occurs. So that should be the message. And you look at the latest guideline from the American Heart Association, American College of Cardiology, and Heart Failure Society of America. They come up with a guideline very recently. And what it says that in patients with heart failure, reduced ejection fraction and NAYS class 2 to 3 symptoms, the use of ARNI is recommended to reduce morbidity and mortality. So this is a class 1 recommendation. Level of recommendation is a very strong recommendation that it has to be ARNI. If somebody is not tolerating ARNI, or when use of ARNI is not feasible, then you can go for ACE or R. Only then. Otherwise, the treatment is ARNI. You should start the patient on ARNI. Then look about acute decompensated heart failure. You know, patients frequently go to the hospital, they get decompensated, diagnosed as heart failure, then they again get admitted because of acute decompensation. Are they different from the de novo heart failure? De novo heart failure are the patients who presented first time with heart failure. You look at the patient characteristic of the two different types of heart failure. And these are the patient obviously hospitalized with heart failure. Acute decompensated chronic heart failure is a old patient, is a older population. They have got worse baseline status and laboratory findings, and they have a known history of underlying heart failure. De novo heart failure, they didn't have any history of heart failure before. Where acute this chronic heart failure, they do have a history of ischemic heart disease, COPD, atrial fibrillation, diabetes, stroke, TIA, or history of previous intervention like PCI or bypass graft. And these things were less frequent de novo heart failure. And the trigger event for them is a poor compliance in taking medication, infection and excessive salt intake, and some cardiovascular complications or interventions. So that has triggered the event. Here, the triggering events are usually cardiac ischemia or valvular incompetence, like acute MI, acute mitral regurgitation, or could be inflammatory cause like viral myocarditis, or toxic like drug-induced myocarditis. The clinical presentation is typical dyspnea, orthopnea, lower limb edema, ascites, and weight gain in a chronic heart failure who has decompensated for a de novo heart failure, basically cardiogenic shock and acute pulmonary edema. And that brings us to this important study, Pioneer Heart Failure. This is basically done in 881 patients hospitalized with acute decompensated heart failure with a LV ejection fraction of 40% or less. These patients were stabilized while still in the hospitals, systolic blood pressure 100 or more in prior 6 hours, no symptomatic lowering of the blood pressure, no increase in IV diuretics in the prior 6 hours, no IV vasodilators, or no IV inotropes in past 24 hours. So this was the criteria for then to select the patient. Sacubitril valsartan was given 200 milligram twice daily, and the other drug that tried was enrapil 10 milligram twice daily. And the evaluation was for NT-proBNP, safety and tolerability and clinical outcomes. And this was a blinded study for 8 weeks. And this is in hospital initiation of sacubitril valsartan vis-a-vis enrapil. When you look at the NT-proBNP level, so there's a 29% reduction in sacubitril valsartan vis-a-vis enrapil. When you look at the CV death or hospitalization for heart failure, so this is one of the main component of the evaluation. So there you see there is a reduction of 42% between enalapril and sacubital valsartan. So sacubital valsartan was far superior than enalapril so far as reducing clinical events like CV death or hospitalization for heart failure. When you look at the specified subgroup analysis in de novo heart failure patients, there are around 27% with de novo heart failure, and out of them 7% were on ACE or R. The rest of them were not on ACE or R. And when you look at the de novo heart failure patients, look at the change in NT-proBNP, they are much more pronounced. Also in de novo heart failure, also in patients who are on sacubital valsartan vis-a-vis enalapril. See, the reduction in NT-proBNP was quite remarkable in patients with de novo heart failure. And the chronic heart failure also, there is a reduction, but the reduction is much more pronounced in patients with de novo heart failure. When you look at the patients who are ACE or ARNI, so these are the patients who are not on ACE or R. You see the NT-proBNP reduction is much more pronounced than the patients who were receiving previously ACE or R. So the benefit appears to be that patients who are not receiving ACE or R before, their NT-proBNP reduction is much more pronounced. Also patients with de novo heart failure. So such improvements in early clinical outcomes would be lost in a scenario of ACE inhibitor pre-treatment. So that is the AC 2021 writing community. They rotate that if you are pre-treating them with ACE or R, probably this improvement in early clinical outcome will be affected. So this is basically the NT-proBNP. There is a 28% less in sacubital valsartan versus enalapril, and these are the patients who without prior exposure to R. So, and when you look at the CV death or hospitalization for heart failure, there is a 48% reduction. So early clinical benefit with ARNI vis-a-vis enalapril, and these are the patients without prior ACE or R exposure. So there is significant reduction in NT-proBNP and a 48% reduction in CV death or hospitalization for heart failure. And this is a new onset, or the patient admitted for the first time for heart failure. Looking at de novo heart failure, 43% overall patients in this is from the global heart failure registry data, where de novo heart failure with rates ranging anything between 20% North America to 79% Southeast Asia. So in our part of the world, we do have a lot of patients having de novo heart failure. So in PREVENT study, 66% are newly diagnosed with heart failure, reduced ejection fraction. So quite high incidence of de novo heart failure. When you look at the benefit of sacubital valsartan vis-a-vis enalapril in this group of patients, so there is a significantly lower incidence of composite of CV death or heart failure rehospitalization in patients who started with sacubital valsartan. These are the de novo heart failure patients started on sacubital valsartan in the hospital itself before discharge. So there, the composite of CV death or heart failure rehospitalization is significantly less compared to a patient who are not started the drug in the hospital. The transition study is in initiation sacubital valsartan shortly after hospitalization for acutely decompensated heart failure in patients with newly diagnosed or that is de novo heart failure. And basically, we'll be discussing about the subgroup analysis of this transition study. So the subgroup are based on heart failure history, like newly diagnosed de novo heart failure or chronic heart failure diagnosed prior to enrollment of the study. So this was basically primary endpoint was the assessed tolerability of the treatment as the proportion of patients who achieved the target dose of 200 milligram twice daily at the end of week 10 after randomization. So this was the primary endpoint, and there is a secondary endpoint of the initiating sacubital valsartan shortly after hospitalization in newly diagnosed heart failure patients, proportion of patients who received and maintained any dose of sacubital valsartan for at least 2 weeks leading up to week 10, and rates of permanent study drug discontinuation due to adverse events. And this was published in 2020 in European Journal of Heart Failure. And when you look at also sequential valsartan, what they found that there is a reverse remodeling. There is what is called a reversal of remodeling with use of sequential valsartan. So when the LV ejection fraction, there is only 6.5% had a LV ejection fraction, which was effectively increased by more than 50. So there are only 6.5%. There's a reverse remodeling with the drug, so that is enrapril. But when you look at sequential valsartan, 30% could achieve the reversal of remodeling. So there is a reverse remodeling, and this incidence is very high in patients with receiving sequential valsartan, significantly more than the reference drug. And so there is an increase in LV ejection fraction, and also LV end diastolic diameter also significantly reduced. Again, a measure of remodeling. So this is basically a measure of remodeling showing significant reversal. So sequential valsartan improved cardiac remodeling and pump function more effectively compared to ARNI, and these are the patients with de novo heart failure patients who are hospitalized. When looking at the troponin T, high sensitive troponin T concentration, this is also significantly reduced in patients with sequential valsartan. And when you the main endpoint was number of patients reaching the target dose at week 10. So this was 56% with sequential valsartan, and this was only 45% with the reference drug. So more number of patients, statistically significantly more number of patients could reach the target dose of 200 milligram twice daily within 10 weeks. And those who achieved and maintained the drug like 100 milligram or 200 milligram twice daily for at least 2 weeks leading to week 10. So that is one of the secondary outcome. That is also significantly more with sequential valsartan. And achieved and maintained any dose of sequential valsartan for 2 weeks leading to week 10. So there was no significant difference. And permanently discontinued sequential valsartan due to adverse event was also less. And this is significantly less those who could achieve the target with sequential valsartan vis-a-vis enrapril. So the transition study, what it shows that the first trial initiation of sequential valsartan de novo heart failure with reduced ejection fraction patients alongside the initiation of other guideline-directed therapies is feasible and is associated with a better risk-benefit profile than in patients with prior heart failure with reduced ejection fraction. Early intervention with sequential valsartan should be considered to delay disease progression in patients with de novo heart failure. So the decision pathway for optimizing heart failure treatment, that was the 2021 updated from the ACC expert consensus. Like any patient with a stage 3 treatment, start ARNI, ACE or R, where they say ARNI is preferred, but 2022 they say that it should be ARNI first. And choice as the foundational therapy along with beta blockers and diuretics. And then you have got choices of other drugs, like patient with the eGFR more than 30 or more with a creatinine of less than 2.5 in male or less than 2 in female, potassium less than 5, you should go for aldosterone antagonist. And then patient meeting criteria of eGFR with NIH class 2 to for SGLT2 inhibitors. And then with the persistent volume overload, of course, you have to up-titrate the diuretic agents. And the patient persistently symptomatic, a black patient, despite ARNI, beta blocker, aldosterone antagonist, SGLT2 inhibitors, then it is hydrolyzine isosarbide dinitrate. And patients with a resting heart rate of 70 or more on maximum tolerated beta blocker dose in sinus rhythm, class 2 to 3, it is evaporated. So these are the winner drugs that are effective in patients with heart failure, except diuretic. All the 4 class of drugs, they reduces mortality also, along with ACE, ARB, and ARNI. Clinicians should aim to achieve optimal guideline-directed medical therapy within 3 to 6 months of an initial diagnosis of heart failure. The European Society of Cardiology 2021 guideline recommends sacubitril valsartan as the first-line therapy for hospitalized patient with heart failure with reduced ejection fraction. Remember, hospitalized patient with heart failure with reduced ejection fraction. This should be stable patients, including those who are on AS or ARNI. Means they may not be on AS or R, and the first time they will be receiving any medication from that class. So it has to be ARNI that should precede AS or R. The 2022 American Heart Association guideline clearly says that in patients with heart failure, reduced ejection fraction and NOH class 2 to 3, ARNI is recommended to reduce morbidity and mortality that we have seen. And if it is not possible, then only you go for AS or R. For some reason, it's not feasible to give ARNI, then AS or R you should be using. If the patient is an NRP 10 milligram or less, or valsartan 160 milligram or less, then the starting dose is 50 milligram twice daily. If the patient is taking more than 10 milligram enalapril or more than 160 milligram valsartan, the starting dose is 100 milligram twice daily. In 2 weeks, assess tolerability and if possible, increase doses stepwise to target reach the target doses 200 milligram twice daily. Of course, you have to monitor blood pressure, risk of hypertension is there, electrolytes, risk of hyperkalemia is there, and renal function. There may be some deterioration initially. So you have to monitor the blood pressure, electrolytes, and renal function after initiation and during titration. But try to up titrate every 2 weeks to achieve the goal of 200 milligram twice daily. The reasons for intolerance to sacubitril valsartan is worsening of eGFR around 22%, but the main cause was symptomatic hypertension. In fact, symptomatic hypertension is a bit more in comparison to enalapril in the trial. And of course, there are some 10% will have some hyperkalemia and maybe have some GI intolerance. And the reasons for failing to achieve target doses, the majority are again symptomatic hypertension, some worsening of eGFR, hyperkalemia, maybe GI symptoms, and others. That brings us also reason to achieve the target doses. Our inertia, we fail to up titrate the doses. So once you prescribe 50 milligram twice daily, then somehow we become a bit reluctant to increase this to 100 milligram or 200 milligram twice daily. But the benefit are seen irrespective of the dose. Of course, remember the doses, the higher doses give the maximum benefit, but the lower doses also they do give benefit, particularly participant taking lower than target sacubitril valsartan doses has a lower risk of primary events compared to those taking lower than target doses of enalapril. So this is not the target dose of enalapril. So giving a lower dose of enalapril, there also you do get benefit with a lower dose of sacubitril valsartan, but remember the benefits are more when you keep the target dose, that is 10 milligram twice daily if you are giving enalapril, and vis-a-vis ARNI we are giving the sacubitril valsartan that's to 200 milligram twice daily. So if somebody is having a systolic blood pressure, say 110 or 108, so whether you should give this drug or not, or whether it is going to be beneficial in such patients or not. So these are the patients where in patients with heart failure with reduced ejection fraction, and these are the patients where you can see ARNI vis-a-vis sacubitril, this enalapril vis-a-vis sacubitril valsartan. So there is a reduction of around 20% overall, even in hospitalization and death, so that we know paradigm heart failure. When you look at the systolic blood pressure less than 110, there is a reduction of around 12%. This is not statistically significant, but there appears to be a reduction in primary event of 12% in patients with sacubitril valsartan, even with a systolic blood pressure less than 110, and with a systolic blood pressure even 110 to 120, there appears to be beneficial effect of hazard ratios of 0.8 for favoring sacubitril valsartan. So even patients with systolic blood pressure less than 120, less than 110. So this drug is showing some benefit in comparison to enalapril. And then when you look at the hypertensive episodes and the outcomes related to the hypertension, when there hypertension occurs, the death enalapril and the hypertension events and the death with sacubital valsartan, you can see the death after hypertension adverse event is significantly less with sacubital valsartan. If that means even if the patient develops hypertension, the benefit is there. The risk of death and hospitalization for heart failure, that is also significantly reduced in comparison to enalapril. So even the patient develop hypertensive episode, the other clinical benefit, the main primary endpoint was also significantly reduced in those patients developing hypertension, and the death due to hypertension appears to be much less than in comparison to enalapril. Basically needs to correct volume or salt depletion. Then start with a low dose. Suppose somebody is volume depleted, so correct that volume depletion. Any salt depletion, correct it, then start with a low dose. In hypovolemic patient, doses of diuretic likes to be required down titration. If the patient is stable, patient is dry, so that has to reduction in diuretic doses or even discontinuation of the diuretic doses. In fragile patients, elderly patients, systolic blood pressure between 100 to 110, a lower starting dose of sacubital valsartan and slower up titration should be done. Start 50 milligram twice daily in such patients. In patients previously on low dose SRR or naive to SRR, a lower starting dose and a slow up titration are recommended. As with any other disease modifying agents, there has to be lowering blood pressure, starts low and go slow. Should be standard correction in the clinical practice in patients prone to hypertension. So maybe instead of 2 weeks, you go for 3 weeks, 4 weeks titration, but try to achieve the highest possible tolerable dose to get the maximum benefit. Remember that some of the patients may not tolerate the highest dose, then maybe you give 100 milligram twice daily for those patients who are not tolerating 200 milligram twice daily. That brings us to this paper published in Egyptian Heart Journal in 2021, titled Will Introduction of ARNI Reduce the Need for Device Therapy in Heart Failure with Reduced Ejection Fraction? And we know that recommendation for implantable cardiac defibrillator, if the patient already had a certain, to reduce the risk of sudden death, all-cause mortality, a patient who has recovered from ventricular arrhythmia causing hemodynamic instability, or the primary prevention to reduce sudden death and all-cause mortality in somebody having NIH class 2 to 3 symptomatic heart failure, LV ejection fraction 35% less, despite more than 3 months of optimal medical therapy, provided they are expected to survive substantially longer than 1 year with good functional status. And they do have also ischemic heart disease like MI prior unless they have had an MI in the prior 40 days. So previous ischemic heart disease history or dilated cardiomyopathy. So they are the patients who should be given implantable cardiac water defibrillator. What is our these are the patients on ICD. So what is that the CRT non-responders, where there's a cardiac resynchronization therapy are given to somebody with a LVV with a wide QRS, given the patient cardiac resynchronization therapy, and their patient is, even after CRT, patient is having frequent BPCs or progression of heart failure. They are replacing S or R with ARNI, improves left ventricular ejection fraction, reverses adverse cardiac remodeling, and decreases ventricular premature contractions and improves biventricular pacing. So a patient on CRT and still having frequent BPCs and also progression of the heart failure, it's time that you replace ACE or R with ARNI. That if in that patient is already not, the patient is not on ARNI. And this is from the Trivandrum heart failure registry. 55% of the patients had hospitalization, heart failure, heart diabetes, at hospitalization and at discharge. And looking at the other studies across the globe, around 30% of the patients of chronic heart failure has diabetes. And the reverse is in diabetic patients, the prevalence of heart failure is approximately between 10 to 30%. So even in patients of diabetic, the incidence of or prevalence of diabetes is also quite high. What ARNI does is that it improves cardiovascular death or heart failure hospitalization and quality of life, irrespective of the glycemic status. When you look at the overall benefit of hospitalization, heart failure, hospital, cardiovascular death, so there is a 20% risk reduction in a patient who has normal glycemia, a patient who is pre-diabetes, patient with undiagnosed diabetes, and patient with diabetes mellitus. So there is no difference in the efficacy. So p-value for interaction, see the p-value for interaction. So the beneficial effect of ARNI is seen across the different glycemic status. Even there, you see, look at the individual component like cardiovascular death, heart failure, hospitalization, even all-cause mortalities, and the improvement in quality of life also, they're all showing beneficial effect across the glycemic status. And interestingly, what does it shows that the HbA1c reduction is significant. HbA1c is significantly low in patients who are on sacubital valsartan vis-a-vis enrafil. The subgroup analysis over a period of 3 years consistently found that HbA1c is low in comparison to enrafil, but the p-value for interaction only for this first year and second year. So there is a statistically significant difference. It's not seen in year 3. But it looks like that patients who are receiving sacubital valsartan has a better HbA1c control. New use of insulin was 29% lower with ARNI versus enrafil, and fewer patients were started on OHS therapy with ARNI. So not only it has a lower HbA1c, the chances of insulin is reduced by 29% receiving, and the new onset, even the patient receiving OHS also appears to be less. That brings us to the other important aspect of heart failure, that is heart failure with preserved ejection fraction. We know that 50% of the heart failure also with the ejection fraction of more than 40%. Now they call 40% to 49% what is called a mid-range ejection fraction. Even in that, or heart failure with ejection fraction more than 50%. So there, basically, if ARNI has a role to play in those patients. Heart failure preserved ejection fraction will not be discussing, so it is quite common. Previous trials have failed. Previous drug trial have failed so far as heart failure preserved ejection fraction is concerned. In fact, the only drug that has come out recently is the SGLT2 inhibitors, both empagliflozin, now dapagliflozin, data presented yesterday, showing there is a significant benefit in heart failure with preserved ejection fraction. Some observational studies showing is a similar clinical outcome with heart failure preserved ejection, reduced ejection fraction. But we discuss about a important trial, that is a Paramount trial. There is several improvements, several subdomains with ARNI in this Paramount trial. NT-proBNP was significantly reduced. Besides, this is a trial where sacubital valsartan versus valsartan was done. So in comparison to valsartan, there is a significant improvement in NT-proBNP with sacubital valsartan. Improvement in left atrial size was also seen with sacubital valsartan comparison to valsartan. And NIH class improvement is also seen with sacubital valsartan vis-a-vis valsartan. Paragon heart failure trial that was in 2017. What it shows that this is basically randomized double-blind active comparator trial testing the hypothesis that sacubital valsartan compared with valsartan would reduce the composite outcome, total heart failure, hospitalization, and CV death. And these are the patients with LV ejection fraction of 45% or more. So basically, heart failure with preserved ejection fraction. So they are subjected to randomized to sacubital valsartan 200 milligram twice daily vis-a-vis valsartan 160 milligram twice daily. The primary endpoint was composite of total fast and recurrent heart failure, hospitalization, and cardiovascular death. Secondary endpoint was improvement in NYHA functional classification at 8 months, changes in clinical this KCCQ clinical summary score at 8 months, and then time to fast recurrence, occurrence of worsening of renal function, and time to all-cause mortality. Heart failure hospitalization, there is a reduction of around 15%. Cardiovascular death is also reduced. It's not reduced, but there is a reduction in heart failure hospitalization, though this was not statistically significant. Yes, CV death, there is no reduction. But there is significant heterogeneity so far as ejection fraction and sex is concerned, where there appears a beneficial effect is seen in females. So there the rate reduced 0.73, suggesting there is a 27% lower risk of primary event if you are giving it to a female, and also with a particular subgroup of patients with the LV ejection fraction of less than 57, so there is improvement. So there is a 22% reduction that appears to be statistically significant so far as primary composite outcome is concerned. When you look at the EF quartile also, the beneficial effect is seen with 57%. So the ejection fraction cut off 57%. If somebody you have given sacubital valsartan with the ejection fraction of less than 57%, then there appears to be that benefit. There is significant benefit so far as primary composite outcome is concerned. When you look at the total heart failure CV death by LV ejection fractions across ejection, means both paragon heart failure and paradigm heart failure data, there also you see if the HV, you look at there appears to be benefit across a particular group till you find that LV ejection fraction more than 60, possibly there is no benefit. Till that time, there appears to be some benefit when treating the patient with sacubital valsartan vis-a-vis other comparator ACE or R, and with the ejection fraction up to 60%. I think the 2020 AHA SEC recommendation says that in patients with heart failure preserved ejection fraction, LV ejection fraction 50% or more, the next to diuretic, the drug is SGLT2 inhibitor. Is a class 2A recommendation. ARNI has a class 2B recommendation, along with mineral receptor antagonist and angiotensin receptor blocker. But ARNI has a class 2B recommendation for symptomatic heart failure with LV ejection fraction of 50% or more. Look at the side effects. The side effects is angioedema is less. Recently, I've seen a patient who had angioedema 3 times, and somehow the patient was done sacubital valsartan. Nobody suggested him that this could be due to sacubital valsartan. So I stopped the drug. He's fine now. No more angioneuritic edema, and so this is one of the complications that can occur. You have to keep a watch and advise the patient that any symptoms or any signs that you feel that this is angioneuritic edema, you should stop the drug and consult the physician. And of course, hypotension is more common vis-a-vis enrapil. You can see it is around 18% overall, or 12% is enrapil. Impaired renal function is seen with this class of agents, but it's still low, 3.3%. Hyperkalemia is 12%, bit less than with enrapil. And cough is there, but it is less than enrapil. Around 9% will have some cough. And when you see the risk of potassium, they look at the potassium level. The risk of hyperkalemia appears to be lower in sequential valsartan vis-a-vis enalapril. So hyperkalemia incidence appear to be less, and incidence of severe hyperkalemia appears to be also less. So this is enalapril. So this is our sequential valsartan. The incidence of overall hyperkalemia and severe hyperkalemia appears to be less with the use of sequential valsartan. Coming to the contraindications, as I told, within 36 hours of ACE inhibitor use, you simply cannot use this drug. History of angioedema or with or without an ACE inhibitor, or you cannot use it. Pregnancy, lactation, severe hepatic impairment, concomitant aliskiren used in patients with diabetes, and patient having a known hypersensitivity to either R or ARNI. You should be careful about patients with mild to moderate renal impairment. There's no need to adjust the doses, but with eGFR less than 30, you should start with 50 milligram twice daily and double the dose bit slow every 2 to 4 weeks to target a maintenance dose of again 200 milligram twice daily. Remember, in the eGFR less than 30 also, the target maintenance dose is 200 milligram twice daily. Only that you have to approach that dose at a slower rate. In hepatic impairment, mild no dosage adjustment required. Moderate starting dose has to be 50 milligram twice daily and double the dose again slowly 2 to 4 weeks. Again, the target dose is 200 milligram twice daily. You have to cautious in patients in renal artery stenosis, systolic blood pressure less than 100, and in patients who are volume depleted, because here the risk of hypotension is quite high. Drug interaction that is contraindicated with ACE inhibitor, aliskiren. Potassium sparing diuretics may lead to increased risk of hyperglycemia. So, particularly in patients with renal impairment, diabetes, hypoaldosteronism regime. So, you have to be careful when using along with a mineral receptor antagonist. You have to monitor potassium level. And non-steroidal anti-inflammatory drugs are has a worse outcome when you use it in patients with heart failure in general, particularly. So, you have to avoid that. And again, the patient, they do have other side effects. So they are a class of agents should be avoided in patients with heart failure. And somebody on lithium, there is increased risk of lithium toxicity and birth control pills also. Strict low potassium diet, we know the low potassium diet. Then smaller doses of loop diuretics. Loop diuretics that reduces serum potassium level. Then you add a potassium binder in emergency situations combined with salbutamol nebulization. We know salbutamol nebulization is used temporarily so that potassium enters from the bloodstream to the cells temporarily. And of course, glucose insulin infusion when the patient coming with severe hyperkalemia, and of course we do have the newer agent that is patiromer, the newer potassium binding agents, patiromer. Suppose the patient have given ARNI started sequential valsartan, patient is doing fine, 2 years, 3 years have passed, then the ejection fraction has improved. So what should we be doing? So do we discontinue the drug or we continue? And this is from the prospective registry data, and these are the patient started treatment with sequential valsartan. This mean follow-up period was 7 months. But you see the ARNI withdrawal, the hazard ratio of these are the ARNI discontinuation of the ARNI leads to 13 times more risk of death. The risk of death is increased by 13 times if a discontinuing sequential valsartan from this prospective registry data. And this is also a cardiovascular mortality and all-cause mortality. They are all significantly increased 13 times if you discontinue the drug in between. So what it says that in all patients with heart failure reduced ejection fraction, or even in patients with heart failure preserved ejection fraction with a EGF with a ejection fraction less than 57%, where the beneficial effect is seen, you should go on continuing the drug even the patient has shown clinical improvement. Because the heart failure ejection fraction and it can land up in heart failure, reduce ejection fraction, and all sorts of permutation combination over a period of time. The ACC AHA guideline management of heart failure shows that in patients with heart failure with improved ejection fraction after treatment, guideline-directed medical therapy should be continued to prevent relapse of heart failure and left ventricular dysfunction, even in patients who may become asymptomatic. So, in those patients where we have given with heart failure reduced ejection fraction, and then subsequently their ejection fraction has improved, so they are in the group of heart failure with improved ejection fraction. There you should continue the guideline-directed medical therapy that includes ARNI to prevent relapse of heart failure and left ventricular dysfunction, even when they are asymptomatic. So the pulse of consensus is that ARNI is molecule of the century and is indispensable, and superior to ACE inhibitors in reducing cardiovascular death, heart failure hospitalization, and sudden cardiac death in patients with heart failure reduced ejection fraction. It also improves left ventricular ejection fraction in heart failure reduced ejection fraction and reverses the adverse LV remodeling and improves quality of life in both heart failure with reverse and preserved ejection fraction. It should be initiated as soon as possible in patients with acute decompensated heart failure and in de novo heart failure. And it should be given for at least 3 to 6 months along with other foundational therapies, heart failure reduced ejection fraction and left ventricular ejection fraction reassessed with echo and CMRI before patient is considered for ICD or CRT. So you are calling, if you are contemplating to give the patient a device therapy, patient has to be on ARNI for at least 3 to 6 months. And this should be used in all patients with heart failure to ejection fraction up to a ejection fraction of 57 to 60%, along with, of course, SGLT2 inhibitors and other guideline-directed therapy like mineral receptor antagonists and beta blockers to reduce heart failure hospitalization and to improve quality of life. Thank you.